In the meantime, I think we can ask for, okay, we're going to just move on to the Crohn's disease cases now. So we're going to start with there's going to be two short cases here. So some topics that we're going to be discussing: management of perianal Crohn's disease, combined surgical and medical management of Crohn's, as well as adverse events associated with anti-TNF therapies. We'll briefly discuss managing recurrent C. diff in Crohn's, as well as discuss some novel medications for Crohn's disease. So case number one, we have a 51-year-old man who presents with fever and perianal pain. So he does have a known history of Crohn's ileitis. It was found in 2011 after he had an X-lap after a motorcycle accident. So he's never had any symptoms. He said he didn't know he had it. So he was started on 6-MP back in 2011, but he's never been very symptomatic. So he stopped this about 6 months before presentation. Of note, he tells you that his father died of complications of Crohn's disease. He doesn't know exactly what happened. So he has pain with sitting. His fevers are high as 103. He's had a 10-pound weight loss in 3 weeks. No diarrhea, no nausea, no vomiting, no abdominal pain. He had been started on antibiotics at an outside hospital, but colorectal surgery there was consulted, and they did not want to intervene on anything at that time. His labs, his hemoglobin was 13.8, his albumin's 3.1, his CRP was 7.7, and his ESR was 60. His fecal cal was 21, and Quantico negative, Hep B serologies were normal. So he had a CT scan at the outside hospital, and it was read as having soft tissue changes in the ischioractal fossa. They thought maybe related to infectious or inflammatory process, and cannot exclude a small right perirectal abscess. They also said there was a focal thickening in the sigmoid colon, and they didn't know if that was chronic diverticular disease, but neoplasm could not be ruled out. So because of this question for diverticular disease, the patient had a colonoscopy done, and the colon was normal. So they said they could not evaluate the terminal ileum, but everything else was normal that was evaluated. So audience response question number one, this patient sees you in clinic for the first time with all these images. He's on antibiotics, and he wants to discuss medical management. What steps do you want to take next for this patient? Okay, it looks like the majority of you would want to do MRI pelvis and consult colorectal surgery to discuss management. Okay, great. So I'm going to have, so basically that's what this patient did. So he had an MRI pelvis done that showed a perirectal horseshoe abscess that was posterior and inferior to the genital diaphragm. And this collection was about 5.4 by 1.6 by 5 centimeters. The CT scan was reread with the Crohn's history, and I think it's very important to make sure that the radiologists have the Crohn's history, and it changed the findings. So he had thickened terminal ileum about 10 centimeters and a sigmoid colon with a questionable fistulous tract opacified with contrast material compatible with an ileocolonic fistula. So I'm going to have Dr. Schwartz talk about some management of perianal Crohn's disease, and then we'll go on with the case.
All right, thank you. All right, so we're going to cover a wide range of things in the brief time here. So we're going to talk about the best diagnostic tools, how we approach this in a multidisciplinary manner, and the optimal role for medical therapy, and how to assess response in patients. So what are the best tools for therapy? So first, before we kind of get into that, I just want to give you a quick overview of sort of the anal canal, and kind of the things to keep in mind would be the intersphincteric space, which is kind of the midway part between the internal and external sphincter, and it tends to correspond to where the dentate line is, usually where we'll see the internal openings of the fistula tracts. The fistula tracts are described based on the relationship in general to the external anal sphincter. And I do EUS, so at our institution, all our patients are assessed with EUS, but I realize most of the places in the country it's going to be an MRI like this patient had. And the kind of nice thing about EUS is these are our patients, so we can just add this on right at the time of colonoscopy, and EUS can actually show you everything that you need to see on the important structures in the anal canal. So you have the internal anal sphincter, the external anal sphincter, and the intersphincteric space, all the three things that the surgeons want to know when they're going to try to decide what to do surgically. So here's an example of what a fistula tract would look like. It's maybe hard to see, but that patient, you can see a skin tag and then an opening in the patient's bottom. And then on ultrasound, you have the probe there in the middle, and inflammation of the fistula tract appears as hypoechoic echotexture, so that very dark area in the sort of upper right-hand quadrant of the screen. And then air within the fistula tract are little hypoechoic beads. That's where the arrow is pointing to. So you can actually put a little pressure with the probe and get the air to move within the tract to help sort of better delineate the tract, or if you are having a hard time finding the tract, you can actually inject a little bit of hydrogen peroxide, which causes a lot of bubbles and makes it a little bit easier to see. MRI is also quite good at delineating fistula tracts, and here's some examples of some different types of fistulas as they relate to the different structures in the pelvis. Again, it really depends on your institutional expertise as to which one to choose. Kind of the main point is to do something, to do some imaging, just because it's quite hard. If you can picture your patient with the worst perianal disease that you've ever had in your practice, you can imagine if you tried to assess fistula anatomy, even under anesthesia, it's going to be very, very difficult to know exactly where that tract goes, and that there are some really important treatment decisions that need to be made based on the anatomy. So it's important to do some imaging to give the surgeon a roadmap to determine what to do next. And our patient, on exam, I'm assuming the reason the surgeons didn't intervene in that initial presentation is they didn't really appreciate the abscess, even though it was quite big. So obviously the imaging kind of clued them in as to where to go and set up optimal results with the exam under anesthesia. And here's an example of a fistula tract on T2 signaling. Because of the inflammation, it'll appear very bright, as you can see in that picture on the right. So we looked at this a long, long time ago now, and we tried to try to help figure out what the best imaging modality that might be to image these people. We compared MRI, EUS, and exam under anesthesia. And sort of the take-home point was all imaging modalities were good, but when you combine an imaging modality with exam under anesthesia, you could actually approach 100% accuracy, which I'll show you in a little bit, translates to a little bit better outcomes for our patients with perianal fistulas. So what about the multidisciplinary approach to these and the timing of intervention? When I came out of training about 15 years ago, the idea of working closely with the colorectal surgeon was sort of heresy. They either went to the surgeon and had the exam under anesthesia and had stuff done, or they went to the gastroenterologist and had medications. We really didn't combine, and we really had some optimal outcomes. And so now we really realize that working together, letting the surgeons kind of clean up all the purulence and control healing really helps our medicines be much more effective. And the first study that kind of looked at this was from Miguel Reguero when infliximab first came out. He looked to see whether exam under anesthesia before starting infliximab made a difference in outcomes, and you can see that those that had the exam under anesthesia before getting infliximab had about half the rate of fistula recurrence. And we recently went back and looked at claims database to show that doing the exam under anesthesia resulted in less cost of care, and their patients are having less chance of being hospitalized, less chance of recurrent fistulas. So not only were we hopefully improving outcomes, but we were saving money because people were doing better more quickly. And the reason why this is so important is fistula is basically a tunnel. It's an abnormal opening in the inside and the outside, and your body wants to close those internal and external openings off because it's not supposed to be there. And so when you start biologic therapy, it really accelerates that process quite quickly, it could happen even as soon as a couple days. A fistula tract can be quite long, and so you have this long area of purulence and inflammation that, if it can't drain, will result in another abscess or fistula, and that leads to more destruction of the anal sphincters. So a seton's sort of purpose in life is just to bridge those two openings, keep the opening open so that purulence can drain and allow our medical therapy to be more effective. So we'll switch to optimal timing. So here's what we have medication-wise. So all the anti-TNFs have looked at fistula healing at some point, either as a primary or secondary result, and you can see that the fistula healing rates over the course of a year is about 30 to 40%. And so we obviously would want to do much better. This is a tremendously negative driver of quality of life, has a lot of morbidity. We'd like to see this be actually closer to about 100% if we could. And as Maria alluded to, one of the reasons why we may not be doing quite as well is because maybe we are underdosing these patients. And so now, because of the results of this study, we're really pushing for anti-TNF levels in the mid-teens, above 15 usually, to really optimize outcomes. And I'll kind of take you through how I approach these patients in a little bit. Now, imaging is also key to improving outcomes, not only through the initial assessment, but also in helping guide therapy. So I like to think of this as sort of the equivalent to mucosal healing. But in the fistula. So we know that people with luminal disease do much better when we can get their colon to return to normal, and people are frequently asymptomatic with luminal disease even when they have active inflammation. So unless you assess it, either with fecal calprotectin or scope, you may not get to that optimal outcome. similar with fistulas. If you fistulas stop draining very quickly with anti-TNF therapy, but there's still ongoing inflammation for a long time after we start therapy. And if we go just by clinical symptoms alone, a lot of times those patients will get recurrent fistulas, recurrent abscesses. So in practice, what normally happens is people get examiner anesthesia, seatons are placed, they start anti-TNF therapy, and the fistula slows down or stops draining about week 6. Inflammation, we know from MRI studies and US studies, persist probably out to about week 20 or more. So we pull that seton at week 6 when that drainage stops. There's still infection and inflammation there, and that increases the likelihood of that fistula coming back. And so what we'd like to do is leave those setons in longer, let imaging be the guide as to help determine when the seton can come out so we can really optimize outcomes. And a lot of different investigators, including myself, have looked at this. So this is a study from Michael Kam's group, and it looked at using MRI to guide therapy. And what they did is they took patients, they started them on either infliximab or adalimumab, and they imaged them at week 22. Those that had a suboptimal response on MRI, they used that as a way to inform dose escalation. So they mostly went from biweekly to weekly adalimumab, and they were able to convert a lot of those non-responders to responders. We've done this in a couple of different studies looking at EUS. And so what we do generally is we do the initial assessment with EUS. We send them to the surgeon, setons are placed, and any abscess is drained. And then we optimize therapy with combination therapy plus an antibiotic. And then we re-image them after drainage stops. Usually we wait about 2 to 4 weeks after the drainage either slows down dramatically or stops. If the EUS shows significant improvement in the fistula tract, so on EUS, what that means is the hypoechoic echo texture I showed you in that first tract becomes heterogeneous. Then we pull the seton and continue therapy. We leave setons in. So in the 2 studies we've done looking at this, we're able to show really significant improvement by using EUS guidance to help guide therapy. The one on the right, the more definitive one, where we had fistula healing rates about 80% at 6 months. So it really, using imaging can make a huge difference. Again, I realize most people are going to use MRI, so we just look for a reduction in T2 signaling in that case before we go ahead and pull the seton.
All right, great, that's great. So Dr. Schwartz, so what would you do what's the next best treatment strategy for this patient now?
Okay, so he's had the MRI, which shows the abscess and fistula, and so I would go ahead and send him to the colorectal surgeon and get things teed up to start an anti-TNF. Okay,
great. And what are your thoughts on the concomitant fistula?
I'm sorry?
He has a 10 centimeters also of ileal disease.
Yes. So that's not uncommon. Most people will have some luminal disease with their perianal disease, so that hopefully would also be addressed with the biologic as well.
Mm-hmm. And Dr. Hommes, what is your medical management for this patient? And when would you consider it?
You mean the dose of?
Or dose, or what would you choose?
I would definitely choose a very intense regimen. Remember, this is a high-risk guy, pretty sick, pretty severe, advanced disease, so he really scores as a high-risk patient. So you definitely need combination therapy. So if you would use an anti-TNF like or infliximab, combine that with 6-MP. But again, I think also an interesting discussion is, would you actually induce him and wait, or would you send him for surgery already to take out his ileal segment? We did have that lyric study that did not show completely clear results in my mind, with the exception of quality of life, but that's certainly something you have to discuss with your patient.
Mm-hmm. Okay, and what are your overall experiences with other agents for fistula healing? So this is for everyone in the panel, for ustekinumab, for vedolizumab. Have you had success with that for these other agents?
Yeah,
just curious.
I'll kick off, but I'll gladly give the mic. When they looked at the Gemini post-study, post hoc analysis, I never liked these analyses, because they're not they're not looking at that primarily. And they came out, for instance, with Vedo saying, hey, there's a clear benefit on fistula. I haven't seen that as spectacular in my practice, although I think that the group the anti-integrin group at itself, where we started in the 90s using Tisabri and stuff like that, we did definitely see the effect. It's been not that impressive. Not that at UCLA we have tons of fistulizing patients different from the East Coast. So.
Okay, and Dr. Abreu, let's say this patient also had a lot of colonic disease as well. So they're in the hospital, they're in the ER, they have active perianal disease as well. Would that change your therapy? Let's say they want to start steroids and they call you. Would you be concerned with the presence of the perianal fistula?
For starting the steroids? Yeah, I mean, I think steroids really do inhibit healing. I think they inhibit healing. Everything has to be kind of balanced, like, you know, with respect to how much is it the severe colitis that we need to, like, get some traction over that and doing some, you know, a short IV steroid thing, or can we get away with just giving high doses of an anti-TNF to get everything all together to be better? That would probably be my preference. You know, as a historical point, the only anti-TNF that actually did a randomized placebo-controlled study for fistulizing disease was infliximab. You know, all the others have mostly relied on post hoc analyses of the data to determine whether it was effective or not. So I agree with Dan that we need to hit this guy hard.
Okay, any other thoughts on the case? I think Dr. Schwartz, you were going to say something.
Oh yeah, I was just going to say, I'm getting back. So there, we just finished a study looking at Vedo for fistula disease. So hopefully that data will be out fairly soon once the last patient finishes, and then the ustekinumab data is being written up. So it's in general, when you look at the group, that the healing rates are about the same with the anti-TNFs. The one thing I forgot to mention in my talk is the new agent. There's a newer agent that is about to start phase 3 trials here in the U.S. and hopefully will be approved in Europe in the next few months. And it's looking at adipose stem cells for these refractory fistulas, and I think that holds great promise with healing rates of above 50% for refractory patients. So look for that to be available hopefully in the next few years.
You know, that's a really important point that wasn't in the slides. I think that one of the pieces of data that's really interesting about these mesenchymal stem cell studies is the fact that if you look at just the placebo group, they did really quite well. And I think that it really highlighted for me how important it is to have a surgeon curettage the fistula tracts no matter what the intervention is, because that's a critical piece. And I think perianal fistulizing disease is an art, and I think David says, you know, it's important to work in partnership with the colorectal surgeons, but often they're two extremes, either the overly aggressive where they cut everything and the sphincters are damaged, or the underly aggressive, which is that there's not good enough control over the septic complications of the fistula tract. So finding in your own circle that person that strikes that balance, and there's going to be a learning curve for her or him as you send them more patients.
Yeah, just very briefly, I love that you guys talk about MSCs because that's really relevant. Yeah. To curettage, you know, the trick for MSC treatment in fistulizing disease is really to pull out all the re-epithelialization from the tract so that you create a wound. Because remember, and we talked about it in this course previous years, MSCs really work on both wound healing as well as downregulation of immune responses real quick. It's a quick procedure, so I'm really happy to get that into the clinics where surgeons basically inject the quadrants of the tract, can do actually multiple tracts, so even complex fistulas, and we've seen tremendous results.
Great. All right, thank you. So this patient he had an IND of the abscess that was performed. He had 4 draining setons placed. And then the plan was for 2 weeks later to have an ileocolic resection with repair of his sigmoid fistula. So that was done prior to considering any medical therapy. So for the audience, I have a question for you. What would you do next? So this patient has the perianal disease seton, where setons have been placed. He has a recent ileocolic resection. So what would you like to do now? What would you start him on? Okay, looks like overwhelmingly you guys wanted to start infliximab and 6-MP. Okay, very good. So we'll go back to our panel. Whoopsie. Whoops. Okay, so he starts infliximab 5 mg per kg plus 6-MP. He has a 6 TGN at 127, and his infliximab trough before week 14 is at 3.9. So Dr. Abreu, how would you change his therapy, or what are your thoughts on this right now?
Well, I mean, you heard my bias. I think he's going to need higher levels. however way you're going to achieve that, higher dosing, more frequent dosing, probably usually both at the beginning before stretching that out.
Yeah. So
And this is a really important time when all this is happening, like the cetons are fresh. You don't want to miss this opportunity to really try to get them closed definitively.
yeah. So we check it again. He gets 10 mg per kg next, and he gets it at week 8 actually. So he gets that next, and it's 6.7. So we can certainly shorten the intervals.
Yeah.
Are there patients where you just can't get levels up? And what would you do in that situation?
Yeah.
Would you increase the 6-MP? Is there a lot of extra benefit in doing that in this patient? Or, or is it just that some patients really can't get the levels? Maybe that'll change over time with healing?
Probably all of the above, actually. I think probably all of the above. I may or may not increase a little bit the 6-MP in this case because, again, our study that looked at the relationship of the 6-TGN levels was really in a group of patients in remission, so I don't think that's exactly this guy. But it's fascinating that even post-operatively, he's consuming. Is that true, what I'm saying? Even post-operatively, he's eating up so much of this anti-TNF.
Right.
And he's not overweight, this guy?
No,
No.
not overweight.
Because there's also that relationship of obesity and perianal fistulizing disease.
Right.
So Jen, may I make a small remark? Maybe it's a little bit out of range, and there's a fellow here in the audience that we do a little, call it a game during consultation, that I say, when we go through algorithms and we choose biologics or escalating immune suppressives, etc. I say, well, what if you're in an ACO? What if you're in a world where budgets become constrained? What if we don't like to call for appeals daily for hours on a telephone? So what if we kind of want to talk about that stuff on cost? And for this particular point in the algorithm, you could actually opt to optimize your 6-MP and just see a 6-TGN, because we know from the New England papers that you do really bump up levels significantly. And the cost associated with just one more tablet a day on 6-MP versus pushing 10 mg per kg is very significantly different.
Yeah.
Very true. So he's on 10 mg per kg every 6 weeks right now, but he's at this point with the 6-MP, and he hasn't had a new level checked yet, so that's still work in progress. Would you go to Q4 for someone like this and try to keep pushing? Yeah. So this is all relatively new. So we'll see what we'll do that for him. So Dr. Schwartz, you had mentioned briefly about the timing for ceton, when to take them out or when to consider. In this, are there patients where you wouldn't consider taking out the cetons, and would this be one of these patients, or how would you go ahead and when would you evaluate the disease activity again?
Yeah, I mean, he might wind up being someone we leave the ceton. And so, ideally, we'd like to get it out and have the fistula closed, but in reality, when someone has like this, a horseshoe fistula, a really complex disease, the goals of therapy kind of change a little bit, and they become more to improvement of quality of life. And sometimes with this complex disease, leaving the cetons in will actually continue to give him a good quality of life. And this is where aligning on treatment outcomes with the patients are really important. And I also tell the patients that we have things coming down the line that might actually get them better, much like the adipose stem cell. So just keeping their quality of life high and then waiting for other options to come out might be reasonable.
Oh, that's great. Okay. So the patient currently has 2 of the 4 draining cetons placed. I think some of them fell out 6 months out after presentation. He's eager to remove all of them, and he asks you if you could stop the medications. We've discussed briefly about how this is a very high-risk situation and that this possibly is not the best option for him. So just in the interest of time, I think that Dr. Schwartz has mentioned about the long-term prognosis and about keeping their hopes up. Fistula healing is very difficult, but there are a lot of wonderful treatments that are coming down the pipeline. So I think that's a very important situation. And then lastly, when would you evaluate for ileal recurrence, Dr. Hommes, in this patient who also had an ileocecal resection?
Oh, I'm pretty aggressive on checking that, and I actually use a scope for that. So post-surgery, within 6 months, I try to convince my patients to.
And after that first surveillance, how often do you do it thereafter?
No, then I'm fine. If there's deep remission, it's not a regular thing in my practice to do, to keep repeating those. That's only when you have biomarkers coming up. in your monitoring strategy.
Okay, wonderful. So our take-home points for this first case: perform careful diagnostic examinations in patients, including EUA and MRI pelvis or EUS if that's available, to best delineate perianal fistula anatomy. 2 is to have EUA seton placement with biologic therapy prior to lead to decreased healthcare utilization compared to no seton before biologic treatment. Also, anti-TNF therapy has been shown to heal Crohn's disease-related perianal fistulas. We'll get more data on ustekinumab and vedolizumab later. And that higher trough levels of infliximab have been associated with greater fistula healing, as well as next MRI and EUS, it would be appropriate modalities to track fistula healing. Okay, so we're going to move on to case number 2. So this is a 28-year-old woman with a history of Crohn's ileocolitis, and she has abdominal pain. So she has a history of Crohn's ileocolitis that was originally diagnosed in 2008. She has 9 centimeters of distal ileal disease at that time. She was first treated with Abreu for 3 months, then Flagyl and Levaquin for another month, followed by Pentasa. Then she was off medications for 1 year. And she has had, repeated bouts of diarrhea, weight loss, abdominal pain, and eventually, sometime back in, about 3 or 4 years ago, she started on adalimumab with 6-MP, she thinks, with a budesonide taper, and basically she didn't like the 6-MP and eventually she was just on the Humira monotherapy. So 4 years ago, this is her CT scan, and at that time she has 9 centimeter segment of terminal ileal involvement, just proximal to the ileocecal valve, consistent with her known Crohn's disease. She has no significant stranding, no strictures or obstruction or fistulas, and she has no other significant small or large bowel abnormalities. So her GI symptoms are improving while she's on the adalimumab, but she develops this. So, basically, what is this, Dr. Schwartz?
It looks like psoriasis,
Right.
psoriform lesion, yep.
Exactly. So she develops a psoriasis, and it's pretty severe. So she stops her adalimumab, and she decides to pursue natural therapies for her Crohn's, but we're still working with a dermatologist to try to get the psoriasis under control. So this is still prior to her seeing you. This is 3 years later, and she still hasn't seen you yet. These are part of her history. So she presents with sharp, crampy abdominal pain radiating to the periumbilical region, usually before and after meals. She has 2 bowel movements a day with blood in her stools 3 to 4 times a week. And at that time, her lab's hemoglobin is 11.3, her MCV is 78, her CRP is at 6.3, her ESR is 35, her percent iron sat's at 7 with a ferritin of 20. She has normal vitamin B12 and normal vitamin D. So this is a busy slide, but basically she has a scope about a month or 2 before seeing you. Normal EGD, her colonoscopy does confirm that she has narrowing inflamed ileum with ulcerated and deep longitudinal ulcers. She has ulcerations in the cecum, as well as she does have some colonic involvement, including the right and proximal transverse, with little microscopic inflammation still noted in the descending and sigmoid colon. So audience response, what would you do for this patient? So this is now several years later, so she's still seeing a dermatologist for the psoriasis, but it's not bad right now. But she does have now increased disease activity of her Crohn's. So what would you do in this patient? So A, would you continue her psoriasis therapy with dermatology and start infliximab? B, would you continue the psoriasis therapy, add Antacort and vedolizumab? C, consider Antacort ustekinumab? A prednisone taper for acute symptoms, or you consider further imaging? Okay, it looks like the majority of you would consider adding Antacort and using vedolizumab. Okay, so I'm going to go turn this back to our panelists. So first, would you consider any other diagnostics in this patient, and would it affect your treatment approach? Dr. Hommes.
No, I would be fine knowing what to do at this stage. So this is, again, pretty severe Crohn's disease. I think I have all the evidence to start induction. So I guess I agree with the audience here.
Okay. And what medical therapy would you consider next, Dr. Schwartz?
I think with their history of the TNF-induced psoriasis, I probably would go with ustekinumab.
Okay. And Dr. Abreu, do you have any thought? What would you do for this patient next? I'm sorry, treatment-wise. Same question.
Same.
As
Yeah,
Dr.
I would use ustekinumab.
Okay.
I probably wouldn't use vedolizumab in this
Okay.
case, yeah.
Jen, maybe because we have Marie here with us today, why does psoriasis develop in anti-TNFs, thinking that you knock out some of these pathways and kind of supporting other psoriasis-driven pathways? Is there anything that you can help us with?
I think that, I mean, I don't have any really great answer, but I think that the very presence of psoriasis in the face of using anti-TNF means that this is not really the typical psoriasis. And in fact, in my experience, even though I would use ustekinumab, it's not particularly great, actually, for this psoriaform reaction. It's not like if you had a off-the-shelf psoriasis that walks into derm's office and they get a shot of ustekinumab, it's like magic. Again, it's just, they smell it and it goes away. But that's not the case for these psoriaform reactions. So actually, the most important thing is having stopped the adalimumab. That's the most potent thing you can do to improve her psoriasis. It's thought to be unopposed interferon alpha, actually, that's driving this kind of psoriaform reaction. So, again, we're getting, I sort of feel like over time we're getting more of the consequences of these, because these are the patients that are well. They've had chronically good levels of the anti-TNF, maybe not super high, but the TNF has been opposed enough for long enough that now we have other things being unopposed. Because, this is all circuitry. So if you've inhibited TNF alpha, other cytokines are now unopposed. And in this case, interferon alpha is the big driver. I actually, don't know. I'll add, for example, another very interesting example, how the biology is telling us something. Anti-IL-17, it's the bomb for psoriasis. Unbelievable. And yet in the world of Crohn's disease, if you antagonize 17, you actually cause a worsening of disease, not an improvement.
Yeah.
Yeah, but
Thanks.
we've had a few cases of that, actually. We've seen that happen, absolutely.
Yeah.
So as far as her iron deficiency, I think we discussed this earlier. For these patients that are severely iron deficient, sometimes an iron infusion is the best way to treat them. So she was started on anticortic ustekinumab before meeting you, and she's here to continue therapy. She's basically said she's leaving in a day. She just said she wanted to continue her therapy, get prior authorization going. So she received her first infusion about 2 weeks before the first visit with you. At that time, the labs before ustekinumab infusion, her hemoglobin's at 9.9, her MCV is at 78, CRP is at 23, and her ESR is at 48 with their fecal cal of 865. So it looks at, her symptoms are her lab suggests she has more severe disease. Her symptoms, though, after she started the anticortin ustekinumab, she says there's no more blood in her stool. Abdominal pain has improved, now 6 out of 10. She has no nighttime symptoms, and she's lost about 15, 20 pounds over the last 3 to 4 years. At this appointment, we discussed, let's do a staging MRE, let's see what's going on. We discussed that she wants to wait. She says she's leaving tomorrow in a few days, going to Spain, Portugal, New York. She's going to be gone for a month. I don't know. So she writes you from New York a month later saying she has more abdominal pain, asking you to do something about it while she's in New York. And she says she's also exploring, she's been taking low-dose naltrexone and CBD oil, and nothing's helping, in addition to the therapies she's already had. So she has low-grade fevers, and she comes back now. She's here to see you. Fecal cal is at 385. Her ESR is at 16. Her CRP is at 1.2. Hemoglobin's 11.8 and MCV is 81. So there's a little bit of improvement there. You get the MR enterography, and sure enough, you see a new extensive inflammatory change phlegmon sinus tract extending from one loop to the area of phlegmon without a clear fistula seen, all in that terminal ileal area where she's had disease in the past. So we also repeat a colonoscopy because we want to understand what's going on with her colon. And at that point, she actually has no colonic disease. So this is somebody who's had colonic disease in the past. So all her biopsies have no histopathologic abnormalities. So panel discussion. Is this ustekinumab, is it working for her or is it not? Dr. Abreu, what do you think?
Well, yeah, is this a real case?
It is a real case.
Yeah, this is actually fascinating.
It's actually real.
No,
I promise.
No, shouldn't have put you on that spot. It's really fascinating, actually. Ustekinumab really works for colitis. And in the subgroup analysis, Crohn's colitis responded well, and there will be data eventually, because obviously this has been put through a phase 3 clinical trial. They went straight to a phase 3 clinical trial to test ustekinumab in ulcerative colitis, and you can imagine that if it works in Crohn's colitis, I'll let you guess the rest. So this is really very interesting, that the ileal segment, my interpretation of this is actually that was unsalvageable. That by the time she came back from her 3 years of marijuana or whatever that she was doing for her Crohn's disease, that was not salvageable. And eventually, over time, it'll pop. And that's what happened. It popped.
So if you had the MRE findings prior to her starting ustekinumab, would your therapy have the order changed? Or would you have tried to treat
I think it's great. That's why it's so great that you already did everything, because I think the issue with a patient like this is if she only had the ileal disease on that MRE, straight to surgery. But because she had the colonic disease, it can't be straight to surgery. You can't commit her to having basically a colectomy or a subtotal colectomy. There's so much on the line. You really want to try to salvage the colon with medical therapy. At least that's what I would do. So I would have done exactly the same thing, even if it meant buying time. And what I mean by buying time is sometimes for these patients that have obstructive symptoms, but I need to buy time before I can send them to the OR, I have them on nutritional, like shakes for several of the meals, and then one low residue solid meal a day, so to minimize basically the obstructive symptoms.
Okay, so we kind of talked about what therapeutic steps we would take. And okay, so Dr. Schwartz, she has a Flagman. How would you manage that in the setting of her immunosuppressive therapy?
Well, if there's something, if there's something drainable, which it didn't seem like there was, then I'd probably send her to radiology to get a drain in. In this case, I think you're kind of stuck probably sending her to the surgeon and having them consider resection.
Okay, so she can't get a surgery for about another month. It's just, timing-wise, it's just
Portugal, Spain.
There's issues with the
Priorities.
surgical. So what do you do? What do you do in the interim?
I might put her on antibiotics, I guess, as well. At that.
So that's what I did. So she got a course of Cipro and metronidazole with the ustekinumab injections, with the plan to go to surgery. So of course, kicking myself, 2 weeks later, she develops loose stools 6 to 8 times a day. So beautiful, C. diff positive. So she gets C. difficile, and she's really pissed at you. She's very mad. So then you treat her with vancomycin, and 14 days later she's great. I mean, she's great after, but 7 days later she starts having diarrhea again, and again she's really upset. And C. diff is positive. So she's developing now kind of a recurrent C. difficile pattern here. So audience, what would you do in this patient? So keep her on prolonged vanco taper until after surgery, but don't postpone her surgery. You can consider vanco a course followed by fecal transplant now and delay surgery until after no evidence of recurrence. Treat this with fidaxomicin, reevaluate, and if there's no evidence of recurrence, go to surgery. Do a vanco taper and reevaluate, and if no evidence, over 3 to 4 weeks, go to surgery. Which one would you do? Okay, all right, so it's kind of a wash. We don't really know what we should do. It's a difficult situation here. So it looks like the majority would want to consider vanco followed by fecal transplant and delay surgery until after there's no evidence of recurrence. Okay, so with this, I think we'll have Dr. Hommes talk to us a little bit about recurrent C. diff and IBD. And in the interest of time, we may have to keep it a little bit.
Oh, when Jen looks at me like that, I know, there's 3 minutes on the clock. We've discussed, and we still need to hear from Maria for the new kids on the block. So I'm really keeping it short because I think 2 years ago we went over C. diff extensively, knowing that it's. And can I have hands up? Basically, who has dealt with tough C. diff in their clinics, right? There you go. I mean, looking at the prevalence rates, it's really rising in our clinics. I think. Really, with some of it is the risk of all the immune suppressions that we push, but it's not the whole story, actually. Let me skip a couple of slides. This is on how, over the years, prevalence rates, you can see that in the folder. We definitely see that that's an excess burden on hospitalization in our clinic work, very significantly so, I have to see. And what do we do? And the jury is really out because stopping all your immune suppression definitely is not, the way forward. Tends to compare that with CMV in the discussion. What do we do? Stop immune suppressants, but we know that the disease will flare horribly. So definitely there's colonization different from infection. We all know that. So if you have no symptoms and you still are colonized, there's no need per se to start aggressive therapy for C. diff. And actually, this is the CDC recommended that repeat testing is not recommended if folks feel good. And the carriage rate for C. diff is higher in IBD than in the general population. So, Jen, I'm going to skip very detailed algorithms on the treatment because they are in your folder. There's one that I'd like to discuss at the end of the presentation. I do feel that we've moved away from first-line therapy being metronidazole and moved to VANC for a treatment in IBD. So I'm going to skip this as well. Just talk about two things. First, FMT. May I have seen hands up for who has used FMT in clinic? What were the response rates that you've seen so far? Was it great? Yeah, me too. Absolutely. There's no really change or difference in colonoscopic delivery over oral. So where we use it now at UCLA is really a colonoscopic delivery of FMT. But there is this study, and Jen, you put this, you rightfully pointed out that in a significant portion of patients, they flare somehow. So if you pull the data, if you look at the analysis, there is a significant proportion of patients after FMT that flare, their UC flares. That means that eliminating C. diff per se does not solve the entire problem. And that takes me back to kind of the days that we've been struggling with CMV as well. So be aware that don't pull out all your immune suppressives in these folks when you are eradicating or when you are giving VANC or you give FMT. So the only slide, and again, I don't have my glasses here, but it's also in your folder. This is a nice algorithm, recent paper. This is kind of your clinical guideline for deciding how to treat. Mind you, I had one fatal case of very severe C. diff in UC many years ago, so I'm really biased. This is really truly a very serious clinical entity if you're really sick. So on the severe CDI, please be aware that and treat it aggressively and intensely. And otherwise, on the left side of the slide, you can basically see what you have to do. First-line treatment of VANC, moving in quickly into FMT if you can do it at your practice, because I think the responses so far have been pretty solid. And I'd like to conclude here.
Okay. So I think, if in the interest of time, we ended up actually going ahead with the fecal transplant for her because her surgery had already been delayed so long and we didn't want to wait too much longer. So she had the fecal transplant delivered, and then within 5 days she was perfect. She was down back to 2 bowel movements a day. She still has her abdominal pain on the right lower quadrant, but she had definitely, the fecal transplant worked for her frequency. So she had a surgical resection, and she had 21 centimeters of bowel removed in the ileum, cecum, and attached appendix, and she had, the margins were uninvolved. So Dr. Schwartz, what would you recommend next in this scenario in terms of medical management now?
I would just continue the ustekinumab and probably also continue, I would do metronidazole as well for the first 3 months post-op.
Okay, so you would continue the ustekinumab in her?
Yep.
Okay, great. And when is the next, we talked about kind of the appropriate time to scope after having a surgery, roughly 6 months out is what we would recommend. So she did continue her Stelara post-operatively, and she had her colonoscopy 6 months later. So now what do we do? So she's had she does have some evidence of recurrence here. So she has I2, meaning at least greater than 5 small aphthous ulcers in the neo-TI. How would you handle this? And I think what I'm going to do next is, so what next steps should we consider in someone like this, Dr. Abreu? So she's already on ustekinumab every 8 weeks. She has evidence of recurrence in her ileum, so at least I2 disease, or maybe it was there already. But what would you do in this situation?
I think in general, in any patient with anything, when you find that they have active disease, I always start with what they're on and making sure that is optimized. So in this case, I check trough levels of the ustekinumab. They're available commercially in various places. I showed you the data that above 4.5 is better than below 4.5, at least as an argument to the insurance companies. We have reasonable success getting it every 6 weeks. I know some of my colleagues, including David, have had success in giving a reinduction of the IV load. If it were up to me, I'd give everyone IV all the time. But again, in the ideal world, you'd reload her, and maybe she needs it every 4 to get the levels optimized. And I think that it's, again, likely that we'll be able to apply some of the same principles that we've learned from anti-TNF therapy in terms of hitting them hard and then being able to kind of back off a little bit over time. But, again, we're still working the kinks out with ustekinumab, because in particular, for all intents and purposes, because of the expense of the drug, even though the company says that it's first line on many insurance plans, I have not found that to be the case, because it's a predicament, because if you've told the patient to use it as a first line, then you're left with having to then talk them into the anti-TNF. So most of the time we're using this as after the anti-TNFs, you know what I mean? So it's already a more refractory group of patients, right, Jenny?
Right,
Yeah.
exactly. Okay, so we increased it to every 4 weeks for her. We did not have the levels available at that time. So I'm going to move on next, because she did ask about what I do if this doesn't work? What other therapies are there for me? And then we're going to conclude with Dr. Abreu's talk on novel therapies.
All right, Jenny, thank you so much for doing such a beautiful job. Okay, so I'll begin by telling you that, it's an exciting time, right? We've had now another, there was that initial thing of anti-TNFs, and I was around for that, right, as a fellow initially, seeing the world before and after biologics. It's a beautiful world. So I want to, kind of follow on anti-IL-12 and IL-23 therapy, and tell you about, this is another, important cytokine pathway. And I want to share the concept that in immunology and in biology in general, this is IKEA, right? These are IKEA or Lego pieces. So you got a good idea, and you just have to swap out different modules in order to have, like, the bookcase matching the desk, and, it's, okay, fine. So IL-12 and 23 are brother and sister. They share a common subunit. That common subunit is P40, right? So these are cytokines where God got the idea, hey, look, this seems to be cool. Let's just repeat this, right? And so if you use an antibody that is against P40, you block both IL-12 and 23, right? And that's ustekinumab. There were others, but ustekinumab is the one that got out ahead of the game. But then animal studies and biology and genetics of IBD told us maybe IL-23 is really the important one, right? IL-23. And therefore, now there are antibodies targeting the unique subunit of IL-23, which is P19. So when we talk about anti-P19, we really mean it's an anti-IL-23 antibody that is specific only to IL-23. Okay, so you know the data. This is the ustekinumab data. Here, the only point I want to make is that, like the anti-TNFs, if someone has been on an anti-TNF before, the second biologics looks the pits. The same is true in ustekinumab. If you've been on an anti-TNF before, if you then use ustekinumab, it doesn't look all that good, okay? By contrast, though, I'm going to show you that there are data on two P19 antibodies, this Medi-2070, which is published in Gastro by Bruce Sands, where all the patients had been on a previous anti-TNF, and actually the majority had been on 2 previous anti-TNFs, and still we saw efficacy, and the orange bars are taller than the blue bars by, like, a good amount, as if they were virgins, right? This looks like virgin data, like never seen an anti-TNF. Risankizumab, was, again, an anti-P19. Again, all these patients had been previously exposed to an anti-TNF, and again, you see there's efficacy in spite of that. So I think that's going to be like a cool subplot to these P19 antibodies, which is that they work well, even in the face of having been on an anti-TNF before. Now, I don't have time to tell you when would you use it first line. Some of it is just, I was going to use a vulgar term, so I won't use a vulgar term, but we can talk about that, but in reality, it's going to be the payers that tell us which ones we're going to use, right? The other important concept that I want to share with you is the concept of the JAK-STAT pathway. So again, in biology, in these Lego pieces, there are receptors on the surface of a cell, and those receptors bind a cytokine, and then that signal goes inside the cell to do something, whether it's making pro-inflammatory cytokines, something downstream. Among those are these JAK pathways, and JAK are enzymes, if you will, that are bound to receptors. And when a cytokine, like IL-2 or erythropoietin or something like that, binds the receptor, it then sends a signal into the nucleus to have something happen. And there are various pairings of JAKs, like JAK1, JAK2, JAK3, TYK1, TYK2. I don't want to saturate you with too many details. And then that complex goes into the nucleus and does something, right? Does something. In any case, there are various different JAK inhibitors coming down the pipeline. I want to talk to you about the one that's going to get approved first, and that's tofacitinib. I know we changed subjects because this is a Crohn's patient, but I just wanted to tell you, because that was the topic, that tofacitinib works very well in ulcerative colitis. It's already commercially available for the treatment of RA. It's commercially known as Xeljanz. In the treatment of RA, this JAK inhibitor works at a dose of 5 milligrams twice a day, but that's not usually a good enough dose in ulcerative colitis. In ulcerative colitis, it's 10 twice a day, although in the maintenance study, even 5 twice a day turned out to be effective. One of the things that distinguishes these JAK inhibitors, at least tofacitinib, actually all the JAK inhibitors so far that I've played with, is that they work quickly. So that's a nice thing. They work reasonably quickly. Within 2 weeks, you can see that there's been a benefit to the JAK inhibitor. Maybe not the full benefit, but some benefit. So that was tofacitinib. All these are small molecules, so they're not going to end in a MAB, right, because it's not a monoclonal antibody. It's going to end in this inib, which is a small molecule that binds to something. So this is filgotinib, and filgotinib is now being tested in both Crohn's and ulcerative colitis. These are data from Séverine Vermeer, showing that it's very effective in the treatment of Crohn's disease. And again, most of these patients had been previously anti-TNF exposed, and it worked even in the face of patients who had been previously anti-TNF exposed. Filgotinib improves the mousetrap and is more specific for JAK1 inhibition in theory, more than in theory. I'll skip that. I can keep talking, Jenny, or I could, I could.
I think just a little bit, just maybe.
Okay, all right.
We can wrap
So,
things up.
so these are considerations when choosing a mechanism of action, and this is completely editorial. So take it for what it's worth. I think anti-TNFs, when you think about biologics, they're generally first line, especially if the patient is sick or if the patient has perianal fistulas. I don't think any of the other stuff, although David knows much more about perianal fistulas. My own experience with using the Vetos and the ustekinumabs as second line to the anti-TNFs is that they don't work as well for those indications. I think vedolizumab could be used first line for ulcerative colitis. I think it's really amazing at maintenance of remission. It's safe with comorbidities. You all know already by now that it takes a while to work. So if the patient is very sick, at the beginning, people would call me from, with a hospitalized patient. They gave them Veto, and they expected that to work quickly. It's not gonna work that quickly, right? Ustekinumab works well in Crohn's disease, especially if they've never been anti-TNF exposed. I think we have to lower our expectations a little bit for those that have been anti-TNF exposed. But certainly I think it's the first choice for loss of response after anti-TNF or a psoriaform reaction, even in spite of what I told you before. And JAK inhibitors seem to work quickly, but may have other toxicities. In the case of tofa, there's a signal that people get more herpes, more shingles when they're on tofa. So we're now going to be using that recombinant herpes zoster vaccine that became available in the last few months. And I think I could probably stop there, and thank you guys for staying with us and alert throughout this.
Okay. All right, very good. Thank you very much. And I want to thank our distinguished panelists here today for really helping out with these cases and for all their teaching. Thank you.
Really, Jenny.